Today, just to let you know, that our sort of aim in these seminars is to bring together researchers across the east of England with an interest in better use of health and data, and to provide an opportunity to share expertise in different types of data and really create a forum to learn and exchange ideas. Today's topic is exploring health inequalities through data. And before I just introduce our speakers, I just want to let you know that we're going to be recording this seminar. So just for that purpose, could you please switch off cameras and just make sure your microphones are on mute during that period. We will stop recording in about half an hour or so when the presenters have finished presenting, and we'll just open up for discussions, at which point please feel free to switch on your cameras and your microphones at that point. If you have any questions during the seminar, please do feel free to put them in chat. I'll sort of look at them and collect them for the end of the seminar. So with that said, as I said, today's topic is exploring health inequalities through data. And our speakers are Dr. John Ford, who is a clinical lecturer in public health at the University of Cambridge and co-lead of the Health Inequalities pillar of Cambridge Public Health, and Dr. Katie Saunders, who's a senior research associate at the University of Cambridge and a statistician at the University of Cambridge Methods Hub. So with that said, I will pass you on to, I think, John, you're going first. And yeah.
Great, thanks. Thanks, Rami. Great to see everyone. Thanks for coming to join us. We hope today will be a really interesting session and hopefully have a good discussion afterwards. So let me just share my screen. The plan for today is that I'm going to talk, give a bit of an introduction around health inequalities and the use of data, and then Katie's going to come and speak and specifically focus on why we use data and the use of data to explore inequalities through cohort studies. And then I'll present again finally to talk about kind of primary care workforce inequalities and a specific example of using primary care workforce data to explore inequalities. So as Swami said, I co-lead the health inequalities pillar of the new Cambridge Public Health, co-leader with Mike Kelly. If you're interested in joining the health inequalities pillar, you can go onto the Cambridge Public Health website and register on the directory there. And the idea is that we're going to create a mailing list for health inequalities activities or opportunities to collaborate. So I encourage you to do that. And I split my time between research and public health practice. So half my time spent doing research, half my time is in currently Public Health England. But I also previously led on health inequalities in Cambridgeshire and Peterborough CCG. So I've got a mixture of both academic and practical experience of health inequalities. So that's the plan for today. I'm going to do a brief introduction, and then Katie's going to talk about data, cohort data specifically, and I'm going to talk specifically about workforce data, and then we'll have a discussion at the end. I encourage you to put questions in the chat as and when they occur to you, and we'll pick them up at the end. So broadly, why do we use data to understand health inequalities? Well, as I see it, I think there's two big challenges which face us in terms of trying to address inequalities, both within the NHS and within public health. One of the big challenges is that there's a lack of consensus about what we mean by health inequalities. So I think we can all agree, kind of broad definition of inequalities meaning avoidable and unfair differences in health between two groups or across the socioeconomic gradient. I think we can all agree that. But for some people, health inequalities is about the differences between rich and poor, or the differences between socioeconomic groups. For other people, it's about social class. For other people, it's about ethnicity. Others still, it's about sexual minorities. For a lot of people in the NHS, it's about variation in services and how it's and the performance of different organizations across the health service. And this, the fact that there's no consensus on what we mean by health inequalities means that the term health inequalities is used all over the place, especially within the NHS and public health, and quite often doesn't have the meaning or consensus on what people mean about it. So that's one challenge, and the consequences that health inequalities is used a lot as a term without much meaning. The second big problem is that people don't really know what to do about health inequalities, especially if we start off with this premise that there's lack of consensus on what we mean by health inequalities. Then it's very difficult for people to agree specific actions if we haven't agreed what we're trying to address. There's also a lack of evidence-based solutions. So one of the criticisms of the academic literature around inequalities is that it has spent a great deal of time describing the problem of health inequalities, but not necessarily what to do about it. Because there isn't a consensus about how we should address health inequalities, then I've labelled this that people tend to reach for fatalism, fantasy, or flamboyancy. And what I mean by that is that when specifically NHS colleagues or public health colleagues don't have a clear idea of how to address inequalities, then it can lead to this sense of fatalism, as it were, that a feeling that inequalities are inevitable. Especially if we frame inequalities as differences in life expectancy across socioeconomic groups. And there can be a feeling, for example, among individual health professionals that there's not much they can do to influence the difference in socioeconomic or in life expectancy across socioeconomic groups. But it could be, we could apply that same logic to lots of different fields of in terms of health inequalities. The second thing, it could lead to fantasy. So this is described in the literature, this idea of a fantasy paradigm. And this is where researchers, practitioners, decision makers collude to think that actually, if we focus on downstream individual actions, they'll be key to addressing inequalities. And you see some of this rhetoric from time to time where it's, for example, in social prescribing or signposting, that there's going to be this huge step change in health inequalities if we can just get people signposted to the right services, or social prescribing up and working properly. When in fact we all know that in reality, the things which drive the big health outcome inequalities of premature mortality and life expectancy are the geopolitical things of unequal distribution of income, wealth, resources, power, etc., rather than the downstream individual actions of, let's signpost people to community services. And thirdly, this idea of flamboyancy, that actually, again, if we don't have consensus about what we're talking about and know how to get there, then there could be a tendency to reach for these quite outlandish ideas without trying to target, without addressing the obvious ones first. So I give an example of being in a meeting a few months ago, and one of the suggestions to address health inequalities was working with one of the Amazon delivery centers to try and improve workplace health. And undoubtedly, working with workplaces to try and improve health, especially those workplaces which employ lower socioeconomic groups, is undoubtedly a good thing. But if we ignore all the things that which we have direct responsibility over in terms of access to services, quality of services, experience, outcomes, prevention, if we ignore all that stuff and just reach for the slight gimmicky type stuff, then we're unlikely to make major progress on inequalities. So that's another consequence of this problem of not quite knowing what to do about health inequalities. And part of this is because health inequalities is not only a nebulous concept, but it's used in different ways. So for some people, health inequalities is this aspiration, I guess a shared values and common goal that we all want to work towards. And it's a way of trying to bring people together, because we all we all want a fairer, more equitable society. And so health inequalities is used to corral people as a term which is used to bring people together. So it's used in that sense, but it's also used in a more technical sense where especially whether it's academics or analysts, where we want to drill down to, well, actually, what inequalities are we talking about? Are we talking about inequalities in access and experience and outcome? Are we talking about socioeconomic groups? Are we talking about ethnicity? And the tension comes when these two meet, when they're used in different contexts and framing, and the framing of the problem's different. And part of the reason why I believe data is so important for addressing health inequalities is that it helps us operationalize this shared common value of trying to develop more equitable and fair society with equal health. And we've done some research which has looked at that. So last year we did a review of NHS long-term plan submissions. So you might remember back in 2019, Theresa May announced, no, it was 2018, Theresa May announced £20 million for the NHS. And the NHS then came up with a long-term plan, which was published in 2019. And then the local NHS systems, these STPs, were asked to create plans in response to the long-term plan. And they all had specific sections around health inequalities. And so we did an analysis of 13 of these documents which were in the public domain. And we found actually that local NHS systems conceptualized health inequalities in a hugely varying way and with quite a lot of vagueness. So they didn't have a clear framework or approach to health inequalities as a concept. We also found examples of use of value judgment, so priorities in some disadvantaged groups over the others, and not a lack of commitment to addressing inequalities, but a lack of commitment for specific actions around health inequalities. So that's kind of led us on to develop a way of trying to unpack health inequalities, and this is something we've recently published, and this tries to, I guess, help local health systems to understand actually when we're taking a data-driven or population management type approach. Actually, there's lots of ways in which we can think about health inequalities. So here we divide health inequalities into healthcare inequalities and health outcome inequalities. In healthcare inequalities, we differentiate between patient level factors and system level factors, and patient level factors are across this kind of patient pathway. So it's things like risk factor management, access, diagnosis, experience, treatment, etc. We can add in other things, whether it's screening, for example. And then there's system healthcare inequalities. So that could be inequalities in funding or workforce, and I'll specifically talk about workforce. And then there's all the health outcome inequalities. So that could be premature mortality due to cardiovascular disease or mental health inequalities. And we know that these health outcome inequalities are actually driven by lots of different things, such as income, education, employment. And they're indirectly affected by these healthcare inequalities as well. And then we can think through these inequalities as three main groups. So one is a socioeconomic gradient. So that could be an index of multiple deprivation, or it could be any other measure of wealth, income, education, for example. And then there's a group of, then there's another group which we call disadvantaged groups. So this could be minority ethnic groups, sexual minority groups, rurality. We could have other ones in there. And these groups and communities are disadvantaged, undoubtedly, but we're not saying that they are by definition vulnerable to poor outcomes. So you do, there's a huge spectrum within minority ethnic groups. There's a huge spectrum within sexual minorities. And you know, I think we need to be careful in terms of stigmatizing certain groups. And particularly think about multiple disadvantage, about how disadvantage accumulates. And then finally, there's a whole group of inclusion health, who by definition are vulnerable because of how they belong to certain communities or their life situations. So that could be people who are homeless or have learning disabilities. So this is one way in which we've suggested about unpacking health inequalities and how we can then start to look at this in a data-driven way across the patient pathway at a system level and tying to health outcomes as well across different groups. So that's a bit of a bit of an introduction to data and health inequalities. I'm now going to pass over to Katie, and then I'll come back to me to talk about workforce inequalities. So over to you, Katie.
Just pull up some slides, hang on. So hopefully you can see my slides. Please send me a message if that's not working. I'm going to talk a little bit about using cohort and survey data to understand and address health inequalities. Let me just go through the next one. I'll talk a little bit about using data to explore inequalities, so some comments about different types of data and how you can access these data. And then I'll give 4 very quick examples about migrant healthcare utilisation, about ethnicity, a comment about data quality, and an example of where we've used healthcare data to look at inequalities and access to primary care with telephone triage, and some comments about sexual orientation. Thank you to John for that really helpful framework for thinking about healthcare inequalities. From my perspective, kind of putting very much a data lens onto it. I would say I'd take a kind of, well, why do we want to use data to study healthcare inequalities? Do we want to look at basic epidemiology, at the causes and mechanisms of disease, at policy research, just to understand and describe inequalities? Are we looking at inequalities for service planning, to understand the needs of the population? Or are we using data to study healthcare inequalities in kind of some kind of evaluation to understand if health services are being delivered equitably, to understand if the changes that are being implemented are having any impact on inequalities? So what kinds of data are there? Well, there's publicly available data at the population level. For people, I'm sure that many people here have come across the fingertips data from Public Health England, but it's a really great publicly available public resource with data on small population areas, looking at the health and healthcare inequalities experienced by people in populations. There's also kind of other publicly available aggregate data. There's organisation level electronic healthcare data, so kind of aggregated at the GP practice or at the hospital level. But then there's person level data from individuals. These are data that you can access from NHS Digital or from primary care research databases. And then there's a kind of final bit of data that we can think about using for studying health inequalities. And these are surveys or cohort data. There are lots of survey collections that can be used by researchers for studying inequalities. NHS surveys, so patient surveys, social surveys. I'll talk a little bit about both of these. And UK Biobank's a really big, important cohort study. It's a cohort of 500,000 people recruited between 2006 and 2010. That's used for all sorts of kind of basic biomedical research, but it's also important for understanding inequalities. It's been quite important during COVID-19 research, despite the limitations. So which one's best? We want to study health inequalities. We want to use data to do it. So, well, I'd say there are kind of there's a big split, and it's really quite helpful to think about this. So if we want to use electronic healthcare records to study health inequalities, they're really good. You get really good in-depth information from health inequalities, from healthcare records on healthcare contexts and on clinical diagnoses, because these are the data that are collected when somebody's in contact with healthcare services. It's a really large sample size with healthcare records from everyone. But what's limited or poorer quality are the personal social data. And then there are health and social survey data collections that often have very rich and detailed information about socio-demographic characteristics, about income, education, or about household. But the sample sizes for these survey data collections vary, and there's limited or poor quality data on health and healthcare outcomes. How do I get the data? If you want to do some research thinking about exploring and understanding healthcare inequalities using data, well, for electronic healthcare records, the kind of big place where you apply to access healthcare data is NHS Digital. In order to make an application to access electronic healthcare record data from NHS Digital, you need, it's not simple. It requires time and a kind of bit of understanding. You need to understand the legal basis under which you're allowed to access the data, to really think about data security, because this is personal level data on healthcare context, really sensitive data. You need to write a full protocol. It can be a really lengthy process to apply for data from NHS Digital. I write here, COVID-19 research may be quicker. There are various legal gateways that are a little bit less lengthy to access healthcare data for COVID-19 research, and it's expensive. You need to pay for the data. So often there's data from both primary and secondary care held with NHS Digital, but CPRD is a primary care research database. So holding data from consultations in primary care, particularly with GPs. It's a commercial database. In general, accessing personal level data from CPRD is much quicker. There's still quite a large cost attached. So cohort, survey and cohort data, actually the access to the data depends on the data owner. In the grand world of GDPR, there's a data controller who's responsible for the data, and they're the person who are ultimately responsible for sharing the data with researchers or practitioners. So it depends on survey data collections. The General Practice Patient Survey is run by NHS England, so to access data from GPPS, you need to apply to NHS England. The Health Survey for England is held by NHS Digital, and so the application for access to Health Survey for England data goes to NHS Digital, and the NHS Staff Survey is another kind of important survey data collection. UK Biobank, because it's a research cohort, has a research cohort application process, and so the application is directly via UK Biobank. And then there are the social survey data collections, and these can be accessed via the UK Data Archive or via ONS. The UK Data Archive, I'm probably talking to people who know about it, but if you haven't come across it, it's a really, really rich and important data resource for understanding health inequalities. Data access is free with very straightforward access for researchers from UK higher education institutes. There's the caveat that access can be slightly more complicated for sensitive fields such as sexual orientation or education data. So a couple of examples kind of having used these data. I'm going to talk about having used data to look at healthcare utilisation among migrants to the UK. A little comment about ethnicity recording in surveys and in electronic healthcare records. A little bit of work we did kind of trying to use survey data to look at inequalities impact of healthcare, health service changes. For this, the examples of the introduction of telephone triage, and a little bit of work, an example understanding health inequalities experienced by sexual minority women and men, for which we've used a variety of survey data sets, so understanding society, the UK longitudinal households, also GPPS and UK Biobank. So the question is, can we look at health and healthcare outcomes measured in survey data? If we really care about studying health inequalities, actually we need to, so John's diagram looking at health inequalities was really important, but we need to think about what are the health and healthcare outcomes we want to measure. One of the real strengths about looking at survey data, particularly social survey data, is that they're population-based measures, may include people who haven't been in touch with services in comparison with electronic healthcare data, which is generated when people have actually managed to be in contact with healthcare services. In an analysis I did looking at estimates from electronic healthcare records and consultation rates from survey data, actually we found the measures from surveys and electronic healthcare records kind of had similar patterns, but they weren't exactly comparable. So again, when we think about using survey data, we kind of need to be very clear about what's being measured. But the big advantage of using survey data for us, particularly in this research project looking about healthcare utilisation among migrants, was that the data were available. We were able to access data to look that had measures of both whether somebody was a migrant and whether they used health services from Understanding Society. And we found migrants use health services less than people born in the UK, and this was explained mostly by age and sex. And this was a project where we'd made an application for person level data to NHS Digital, and the application had taken 3 years and been turned down. So for this project, actually, the survey data collection for understanding this bit of healthcare utilisation was really important. This slide just talks about the accuracy of recording. The graph looks at ethnicity recorded in electronic healthcare records in secondary care, is this example. It's from work done about 8 years ago now. And then the recording in the survey response, and the two were linked together. And we find in the top corner, but if your ethnicity, if you have a white British ethnic background, your hospital record and what you say your ethnicity is match really quite well. However, if you look at for the next group of ethnic backgrounds, for people from Pakistani, Bangladeshi, Indian, Chinese, Caribbean and African backgrounds, electronic healthcare records and survey records kind of agree reasonably well in terms of what's recorded in the healthcare records. But then if you look at mixed and other ethnic minority backgrounds, actually electronic healthcare records aren't really recording very well at all what somebody says what somebody would say their ethnicity is. So kind of, this is a bit about thinking about the differences of what's recorded in surveys or electronic healthcare records. My third example, I'm whizzing through them, some kind of examples of thinking about how we can use electronic healthcare data. This is a project that's still ongoing. Looking at the inequalities impact of introducing telephone triage is particularly important in 2020 as primary care has kind of switched over to a telephone triage model with the COVID-19 pandemic. If you want to use data in order to evaluate the inequalities impacts of service innovations, the intervention needs to have worked in the first place. You need to have had something, you need to have known that your intervention has actually done something before you can start looking at whether it's worked better for some groups rather than others. You need a big sample size if you're going to be looking at inequalities impacts. You need to be able to access the data. I've talked a little bit about difficulties in accessing data. And you need to have measured actually the characteristics of interest, what you want to measure, the groups you want to understand inequalities in. We looked at this using Understanding Society. It's a really important COVID-19 data set. The survey went out into the field during 2020, and we looked at responses to the survey in time, questions about healthcare access. We also looked at responses to GPPS from before the pandemic. We looked at a question that asked, thinking about your situation now, have you been able to access NHS services? And then we recoded the options for this question to look at whether somebody had needed to go to the GP, whether they'd tried to contact their GP, whether they were able to contact their GP, and whether this was online or face-to-face. The first graph I'm going to show you, I've only got one graph, but this graph tells us the percentage of patients who tried to access primary care during 2020, if they had a problem that they'd normally go and see a GP about. And we see that actually in April 2020, only 80% of people who had a problem that they needed to go and see a doctor were contacting their GP about this. But by July 2020, actually, this had got back up to over 90%. And then we looked at the inequalities impact of introducing telephone triage for people living with multimorbidity. And what we found here, there's a lot of words on the slide, but what we found that actually people with multimorbidity were more likely to have a problem that meant they needed to access primary care, but we found no evidence that there was any difference for people, whether they tried to access a GP if they had a problem, whether they were able to access a GP, or whether the appointment was online or face-to-face. So actually what we find here is that primary care, that there are differing levels of healthcare need among people with multiple long-term conditions, but actually no evidence of different access to primary care once somebody needs to contact a GP. And then my final example, stepping slightly sideways, looks at sexual orientation. In 2010, the Equality Act brought in a statutory duty on public bodies to monitor and address inequalities in the delivery of public services. And actually this meant that public bodies started collecting information and the data got better. So it suddenly became possible to evaluate outcomes, even if the outcomes haven't improved yet. Surveys provide the bulk of evidence that around LGBTQ+ health disparities, as recording in electronic health records is poor. And we've just done a little bit of work looking at UK Biobank and sexual behaviour, some of the sexual history. And then we compared this with data from NatSal, which is the National Study of Sexual Attitudes and Lifestyles. And it's also available from the UK Data Archive. So here I've just put in this an example, kind of even very, but often there are data available via the UK Data Archive or other routes if you're thinking about particular health inequalities. So very briefly, sorry. In some ways, survey and cohort data are to social science kind of what the big telescope is to physics. They're really rich social and socio-demographic data that are often not available in kind of traditional healthcare data sources. Data access is often straightforward. Cohorts need to have asked the right questions at the start. Sample sizes are generally smaller than electronic healthcare records, and some measures of health and healthcare utilisation are less good. And then there's kind of the final point is that you kind of need to think about the right data set to answer the particular question, to think about why we want to study health and healthcare inequalities. Thank you. I should have, I'll stop screen sharing.
Thanks, Katie. That was a really helpful overview. So I'm just going to finish off by just giving you another example of how we've used inequalities analysis to look at primary care workforce inequalities. So in terms of just a general overview, this project kind of came about from a MPhil project from last year. I guess I thought I would just start with a few reflections on any inequalities project. So I think before starting, there's some really key questions which need answered, which Katie's alluded to, in terms of what exactly is outcome. You know, is it a clinical outcome? Is it in terms of access, or is it a quality measure? And then having clarity in the population, is it you know, you're most interested in socioeconomic or ethnicity or something else, and also the levels. So we can look at inequalities at a national level, so look at what the difference is between socioeconomic groups nationally, but we can also look at them at a regional level. So for example, East of England, or at a system level. So that might be, for example, Cambridge and Peterborough, or Norfolk and Waveney. Or we could look at it at an organizational level. So we could look at inequalities within a hospital trust or within a GP practice. So having clarity on each of these part of the puzzle is just fundamental to looking at inequalities. I think there's then other thoughts around, well, how do we look at inequalities across the patient pathway? So I kind of presented earlier a way of unpacking health inequalities, but what we don't want to miss is how inequalities accumulate as well across a patient pathway. So, you know, although the inequalities may be small at each step, actually they accumulate. And what's a cumulative effect across a patient pathway? And linked to that is also this idea of multiple disadvantage. So again, we can look at inequalities. For example, we could look at inequalities across ethnicities, or across rural and urban areas, or across sexual minorities. But in fact, what's often the case is it's when there's multiple disadvantage, when it's not just belonging to minority ethnic group, but it's maybe also if you on a low income and you've got low social support, and you live in a rural area, for example. So it's how we also consider multiple disadvantage in our data as well. There's also, I think, one of the sticking issues is how we assess populations, and specifically around socioeconomic status. What's quite often done with routine data sources is applying an IMD score, the Index of Multiple Deprivation score, based on either patient postcode or practice postcode, and just acknowledging that that reflects the area deprivation, not the individual deprivation. And that's where the cohort studies, which Katie has talked about, provide a much richer sense of what the individual level socioeconomic status is. And then finally, in terms of analysis, are we thinking about looking at the health gap between two groups, or are we more interested in the gradient across groups? And then what are the potential confounders? Again, this is particularly relevant for routine data where there are often confounders which you just don't have data for, and how do we adjust for those? So to give you an example of primary care workforce inequalities, for me, two of the pillars of an equitable healthcare system are equitable funding and equitable workforce. We know that the demand for primary care services is increasing, and that there's a shortage of primary care doctors. This has led to the introduction of primary care networks and additional roles such as physician associates, pharmacists, paramedics, etc. And we know that GP supply has been linked to better health outcomes, such as mortality rates, health and life expectancy, acknowledging that that might be an association rather than a cause. And so we undertook an analysis to look at workforce inequalities over a 5-year period using the NHS digital organizational level data sets. So they're publicly available. They're published quarterly, and the data is submitted by practices and then published by NHS Digital. And it covers various different roles in primary care. And I'm just going to touch on GPs and nurses, although we do have data for other specialty or for other roles as well. And we focused on producing the slope index of inequality with adjustment for the Carhill formula. And just as a sidestep in terms of the slope index of inequality, so for those of you who aren't familiar, the slope index of inequality is essentially a measure of the gradient of the slope. So in this case, what we did was we calculated the number of staff per 10,000 patients, and then we split that into deciles. And when we split it into deciles, then we could look at the socioeconomic gradient. And the slope index of inequality is essentially the steepness of that slope, or the coefficient, for those of you familiar with that kind of language. So you can understand that if the slope is not very steep, there's not much inequality. If it's very steep, there's a lot more inequality. And you can then measure how that steepness of the slope changes over time. There's different ways of presenting the slope index of inequality. Traditionally, it's the coefficient, and that relates to the difference between each decile. So as you move up each decile, the change. But you also see it presented as a gap between the bottom decile and the top decile as well. So this is what we did. We looked at the slope index of inequality, the steepness of that slope over time. And this is the data for general practice for GPs. And as you can see, 0 would be no health inequalities. The solid line is adjusted, the dotted line is unadjusted. So looking at the unadjusted data, you can see that there's been an increase in inequalities in the distribution of GPs over the time period. And actually, when we adjust for the Carhill formula, so these are measures of GP workload, then actually that inequality is worse. And just to give you an idea, it's to the tune of about the gap between the least deprived decile and the most deprived decile is about 0.8 of a full-time equivalent GP, or 1.4 after judgment. So a reasonable amount, that's about 1.5 GPs difference between most and least deprived decile. When we do it for the for nurses, we see an opposite pattern. So again, the dotted line is the unadjusted data, and you can see actually there's a pro-poor inequality. So there's more nurses in more deprived areas. Although when we adjust for the Carhill formula line, it's a pro-rich inequality, although you see the confidence intervals overlap 0. The difference is much smaller. So we're talking about 0.13 of a full-time nurse between the most and least, between the most deprived decile and the least deprived decile. And there's likely to be some kind of substitutionary effect here, where areas with a lot of GPs have fewer nurses, but more deprived areas which have fewer GPs try to recruit more nurses. Although you can understand that it's not a direct substitution, and that there's not a oversupply of nurses in more deprived areas. And what we did then was we then put this onto a patient on a dashboard, and I'll just show you what that looks like. So this is now hopefully you can see this. Let me try again. So we use that data to put on Tableau a dashboard. So this means that each individual health system in England can see what their own inequalities are. We've got it for GP, for nursing, for total direct patient care staff, which is all other direct patient care staff, so physios and pharmacists and phlebotomists, etc. And so, for example, if you click on Cambridge and Peterborough, you can see that the within system inequality in GPs, which again follows this pattern with the least deprived areas having more GPs, most deprived areas having fewer GPs. Whereas when we look at nurses, we see an opposite pattern, where most deprived areas have more nurses, least deprived have fewer nurses. So this was again a way of trying to operationalize the data and thinking through the different levels. In conclusion, I think using data is just fundamental to operationalizing inequalities and really putting flesh on the bones of this nebulous concept. And it's only when we are able to put data on it that we can then start understanding what needs to happen and how to close a gap. As hopefully you've seen, there's lots of different data sources, and there's lots of different ways in which health inequalities can be explored from lots of different angles, and there's no one way to do it. But the key is having this clear, logical approach to unpacking the problem. So I think that's us finished with the presentation.